Well, we're going to start the last session, session 8, aorta, and the two Italian Americans here, Coselli and Roselli, are moderating. I have the pleasure of introducing Joe Coselli, who's going to speak to us about the state-of-the-art evolving management of complex chronic dissections. Joe?
So we got the mafia going here. It's all right, though.
That's right.
I don't know about state of the art, but I can tell you it's truly an honor to be here. I mean, I wasn't here yesterday. I heard it was fantastic. Today has just been absolutely amazing. Particularly, I've enjoyed the technical tips and tricks aspects about things. I think it's a lot of information we can all take home. Morale, and you don't. If you know morale, you don't argue with morale. Morale. So we'd like for you to talk, but we don't want you to talk about the aortic root and the David operation today. So I'm going to stay away from that. We're going to talk about the aorta a little further distally. These are a few potential disclosures. When I was a younger surgeon and I was beginning to do a lot of thoracoabdominal aneurysms, I was invited to Poland to do some cases, or a case or so, and Dr. David was there. He was already a luminary, a giant in the field, and I got, for the first time, not having been to Toronto, watch him basically do a live case of his David operation. I really thought I was watching Leonardo da Vinci painting the Sistine Chapel. It was just truly, truly amazing. So we're going to talk about dissections. I don't know about y'all, but I think all dissections are complex. Maybe that's just me, but this is what we end up looking at a lot of time for acute type 1 aortic dissections. The incidence is about 3 to 6 per 100,000, but it does vary, and I'll explain that in just a second. Chronic dissections are a little bit different animal, of course, and so they have to be taken under consideration in that way. This is that famous Anastopoulos paper from '72 with a 50% mortality at 48 hours and then an 84% mortality at 1 month, just underlying the fact that this is a really disastrous problem. The global burden of aortic disease, at least in this report, kind of indicates that it certainly hasn't gone down. Maybe some problems with less smoking and this, that, and the other have, but aortic dissections are still with us and are going to be with us for some time. This is a very interesting study from Japan where they looked at CT scans as autopsy imaging, and instead of doing a regular autopsy, they did imaging CT scans on patients who came in who had passed away, and particularly those that had had arrests on the way into the hospital. And the pre-hospital death was observed in just about 50% of the patients, which is about double what other reports had. So this is not only a bad problem, it's with us. With regard to how we describe these things and classify them, we grew up, it was acute if it was less than 2 weeks, and if it was chronic, it was after 2 weeks, but now we've got to deal with hyperacute, acute, subacute, and chronic, and they have some uses. I like to talk a little bit about history. I think it's entertaining for me. If somebody wants to go to sleep, try not to snore while you're bothering the people at your table. But I was described by Morgagni, and then Frank Nichols did the postmortem on King George II. While having a biology event, he ruptured and died, and they did an autopsy, and he had an aortic dissection. Well, that led to George III, and George III was a little bit of a pill to deal with, and so he came across this other fellow, and things changed across the Atlantic, but we like to think that well, especially after the War of 1812, we've gotten along hopefully quite well. The first successful repair was a series of 6 patients by Cooley and DeBakey and Creech, and 4 of the 6 actually survived. This is from that paper, and you can see just little drawings of those six patients, and 2 of them had actually involved the ascending aorta, but they operate on the descending aorta, and interestingly, the patient that was 72 years old survived, the 43-year-old did not. And in those days, they did a lot of just divide the aorta, close off the false lumen, and then sew them back together. Those were in the paper, but then they began to move towards replacement, and so most of those cases were done with homografts. Dacron grafts hadn't quite come in. The first successful acute proximal aortic dissection, or type A, type 1 dissection, was 32-year-old physician operated on by George Morris at Methodist in Baylor, and he lived for decades, decades after that. And he was just an example of dividing the aorta. He resuspended the aortic valve a little bit and then closed it off. Dr. DeBakey worked for a long time trying to come up with a classification. He started out with a report in 1961, but the classification as we know it actually was reported in 1965 on 179 patients. That was his model of DeBakey type 1, 2, in 3 dissections. And a couple of things here again, some of these early cases were just simply dividing the aorta and suturing them back together like George Morris had done. I think it's important to remember that he was using antegrade cerebral perfusion back then. Also in this drawing you might know that we used to do a lot of left ventricular decompression through the apex, but that's not done much anymore. But then they moved towards replacing things with a Dacron graft. These are just some more cases from that same thing. Notice on the descending thoracic aorta, they're using left heart bypass, not too dissimilar as to what we've continued to use for a number of years. The mortality rate in that paper was interesting. It went from 41% in the early years down to 12% in the latter years. And then came along Dr. Daly and Shumway, and they didn't like the DeBakey classification, so they came up with the Stanford classification, which is basically a proximal or distal only, and Stanford A and Stanford B. This is actually based on only 35 patients as opposed to Dr. DeBakey's 170 some odd patients. And they did note, though, that the patients treated medically for the descending thoracic dissection actually did fairly well, whereas in the ascending aorta, you're going to do better if you operate on them. No change from, we haven't really changed from what we know. So if you look at that, the number of patients with a descending dissection in that study is actually too small to allow definitive conclusions on whether or not surgical management was true. But they also, he goes after, he says, Dr. DeBakey and his co-workers proposed 3 types of dissecting aneurysms, again in part associated with the distal extent. But the distal extent of the dissection has not been found to be of any significance determining the primary therapeutic approach. And from this therapeutic standpoint, it is suggested that the aortic dissection classification be further simplified to designate whether or not the ascending aorta is involved, et cetera. Well, Dr. DeBakey didn't take too kindly to this. And so he came back with, this made no sense to me because the 2 types are entirely different and require different surgical approaches. And you can see some of his other comments up above there. In fact, he just basically said, I never liked the Stanford classifications, and these are completely different scenarios. So the boys were throwing some sand in the sandbox. However, I might say that Dr. Miller came along and actually brought some peace between the two programs, and everyone got along quite well. I remember when I was a young surgeon, so this would have been in the early 80s, Dr. Stanley Crawford. Dr. Miller was in town for a DeBakey Society meeting, and Dr. Crawford had invited him, and he said, you keep an eye on this young man. He's already made a lot of contributions, but is going to continue to make many, many contributions in the future, and I think he's certainly lived up to that, and Dr. DeBakey enjoyed wearing his hat in that picture. The point of this slide is that there's a lot of other classifications that have been added since then, but simplification in recent years has actually not been part of the process. But he then described 527 patients of type aortic dissection. And what his point was to follow the distal aorta after that. And the 20-year survival rate, interestingly, was only 5%. What they really found was the patients with hypertension that wasn't well managed, those are the ones that got into a lot of trouble. And so you can see here in the 2 curves with the high risk, which would be the severe hypertension versus the ones without. And again, this is probably no surprise to any of us. A little more updated information, and this is not too much of a surprise, but at 5 years, 68% survival, 10 years, 53%. So it's a bad disease. So we go back to DeBakey again for a second. Dr. DeBakey, in the December of 06, went to the emergency room with chest pain and got a CT scan. And we're not really sure what happened to the resident who told him that he had a type A dissection, but that's another story. Anyway, you've probably never seen this, but this is actually his CT scan that was done in January, right after that. And he really was diagnosed with a dissection on this scan, and he had at least an intramural hematoma. Here it was just a little bit later. You can see how this thing was developing. So he went up, it finally got up to about 7.7 centimeters. He was in renal failure. He was intubated and really going downhill fast. And finally, Dr. George Noon operated on him, replaced his ascending aorta, did a little hemiarch, and he went on to live for about another 18 months up until July of 08, 3 months shy of his 100th birthday. Probably the only, and so when we think about these older patients getting this operation, he always comes to mind. So this is his study about a little less than a year later that it's up against the back of the sternum, but it certainly looks pretty good. He and Dr. Cooley, after he had his dissection, maybe after he had a little circ arrest, the hypothermia, they changed minds a little bit, and they finally buried the hatchet and got together. So we talk a lot, and I know Joe Bavaria does this, talks a lot about going beyond the arch, just not these hemiarch and these total arches, and we're going to hear a lot more about that here in the next mentions, where there's a lot of tools in the chest and extending beyond the arch. This is just a few listed here: hemiarch with an open T-VAR, the Be Safer sort of thing, AMDS, et cetera. So we got a lot of options we can use, and we're going to be hearing a little bit more about when and do that. And then, of course, the Thoraflex is an option. But I might throw this out. This is a Canadian registry looking at 9 centers, and the total arch replacement, you can see the operative mortality is higher than the hemiarch, and stroke rate is almost triple. So it has to be, when you go and remove the whole arch, you have to take it very, very seriously and do the right thing. So what happens to the distal aorta after these acute dissections? This is a study, very interestingly. Why are we going to do this beyond the arch? Well, when you think about it, and at least this study, I think Bo Yang was the senior author on this. They compared hemiarches to zone 1, 2, and 3 and found no significant difference in the long-term survival, distal growth, or reoperation for distal aortic aneurysm. Paraplegia is what we focus on. We are concerned ourselves. Dr. David mentioned this earlier today, and what devastation this is to the cost and to the family and stuff, and it really tears us up from the inside when we have this. So I looked at 3,400 or so of my arch repairs, and 386 had previous ascending or hemiarch operations. And when I went back and when I did this 386 cases, I did total arch replacements on over 60% of them. And it's a pretty high-risk group of patients, but the mortality rate was under 10%, and the stroke rate was just a little over 5%. So Dr. Morale said, even though the rest of the portion of this session is on the arch and whatnot, that I could talk a little bit more of the thoracoabdominal aorta, and he agreed. So this is kind of what I'm talking about. We got the acute dissection, it gets fixed. Now the thoracoabdominal gets big. We have to deal with it later. These are the kind of things, the type A dissections and the type 3s, they require later operations. This would be an example, the kind of thing we see now. This is an endovascular stent graft, aneurysm's getting bigger, patient's symptomatic. We took it out and did an open operation. He then comes back. Now we worry a lot about bentals with later dissections of the descending. This is descending with a later type A dissection. This patient had connective tissue disorder, so I went in and replaced the root. Young patient, I did a mechanical valve and debranched and whatnot. And so then it comes back later, and we got to replace the thoracoabdominal, so he ends up with this. And we think everything is hunky-dory up top, but then he develops a pseudoaneurysm up there, and I just drop a stent graft across it, and so far he's doing fine. So we see a lot of this continuation of operating on individuals. So the distal false lumen patency really does vary, anywhere from 30% to almost 90%. Aneurysms develop in over a third of those patients, and aneurysms develop in almost for half the patients with residual chronic dissection of distal after type A dissection, which you're going to hear more about later. And this is kind of what I'm talking about. Had a bental, and we went back and replaced the aorta. When do we do it? Well, if it's over 6 centimeters, unless they've got a connective tissue problem, and then we drop it down to about 5.5, and we can throw in some high-risk features from this Isselbacher and Provenza from Jack in 2022 guidelines. But I think it's important to keep in mind that these Marfan patients, Loeys, Dietz, VEDS, and et cetera, need open repair as opposed to an endovascular operation. I think it's also important is when we think about these things that there's really no good score on, like we have for the STS-PROM and the Euroscore for the proximal aorta. These risk models are not validated for the type of aortic surgery we were talking about. So I'll go through just a little bit of what we do. We use a right lateral cubitus position, double lumen in a bronchial tube, single ventilation. Usually the 6th intercostal space, I divide the diaphragm so that I can keep most of it, but we want to get total exposure. We use CSF drainage. We did a prospective randomized trial a number of years ago showing that if you use CSF drainage in these extensive aneurysms, it makes a difference, and it's part of the guidelines now that not only for the high-risk patients, also for delayed spinal cord dysfunction, which does occur. You can also, when you operate on these patients after they've had an elephant trunk, use epi-aortic ultrasound to identify the distal end of that thing. We also have used left heart bypass a lot, particularly on the extent 1s and the extent 2s. On occasion, we'll find a patient who just the iliacs and femorals just simply aren't accessible, or pathology or whatever, and then maybe they have a kidney transplant coming off of the iliac, and so we may do the distal first and then go back and reperfuse it, and then basically do the operation from the bottom up. We've never really studied with prospective trials left heart bypass, but we did find in large numbers a retrospective analysis that these large extensive aneurysms, particularly the extent 2s, that left heart bypass does make a difference. In recent times, we've moved towards using an ECMO circuit. One of the reasons we use left heart bypass as opposed to cardiopulmonary bypass is cardiopulmonary bypass, you have to give a lot of heparin, got to get the ACT up to 450 or higher. With left heart bypass, you can deal with an ACT of 250 or less, and that's a lot easier on the lung. Well, these ECMO circuits, you can do this, have an oxygenator, a heat exchanger in circuit, and have an ACT of down to 250. So we begin to use these. Well, actually, one of my associates is presenting some data on a series of these we've done at the SVS this week. So, but it can be used as you use left heart bypass with this in circuit, or a substitute for cardiopulmonary bypass. Either way, we're finding it makes has a lot of use and makes a difference. So we cross-clamp protecting the vagus and recurrent laryngeal nerve, cross-clamp the left subclavian, and a dissection. Usually we cross-clamp proximal to the left subclavian. We've got all that left heart bypass circuitry in place. I think it's important to separate the proximal aorta from the esophagus before you do the anastomosis. And suturing into previous elephant trunks grafts is truly a pleasure, as opposed to some of the really bad aortic tissue that we have to deal with. Move the cross clamp down to restore flow to the left subclavian artery, and then proceed with repair of the rest of it. We'll usually march the cross clamp down a lot. Sometimes we'll just take it off and then deal with it. And we'll perfuse cold into the kidneys, cold and oxygenated blood into the celiac and the SMA. Both of them have been getting oxygenated blood recently through that ECMO circuit that we've been using. Cold blood has been recommended in the guidelines for protection of the kidneys, and if they've got problems with the renal arteries and visceral vessels, stenosis, calcification, et cetera, to go ahead and deal with that when the operation is open. Although we've moved away from this, we had been doing a series of cases with custodial, following the group in Milan with Roberto Chiesi and Germano Melisano. And I'll do an endarterectomy of the celiac, SMA, and left renal, but I don't want to do an endarterectomy of the right renal because it goes away from you, and if there's a shelf, you can't get to it, so we're more likely to put a stent in there, like you see here. You just do that under direct vision. So we found that reattaching intercostal arteries makes a difference. This is probably I've diverted away a little bit from what Dr. Crawford didn't quite buy into this, but when I've looked at over 1,000 extent 2 thoracos, reattaching intercostal lumbar arteries reduce the risk of paraplegia and paraparesis by 62%. This is a Marfan patient. We don't hesitate to replace the iliac arteries. So this is cannulating the left atrium on a case, and this is cannulating the descending thoracic aorta just above the celiac axis, because in this particular case we didn't want to go below the renals. And so then we cross clamp distally. I'm compressing the aorta there so you can see that that you have full control, and there's not a problem with the proximal clamp. Separated from the esophagus. This is speeded up for time purposes. And get a decent sized clamp in there, do the proximal anastomosis, usually with a running suture. Sometimes it's reinforced. This particular dissection had a situation where there was some healing and thrombosis proximally, so we didn't have to clamp proximal left subclavian artery. So then we take the cross clamp off, open up the rest of the aorta. And what you do is you take the wall between the true and the false lumen, basically create a single lumen, and then begin the reconstruction. If you're going to use a multi-branch graft, we reattach intercostal arteries next, and then we do the distal and come back and do the viscerals. This is placing the perfusion cannulas into the celiac and the SMA, and then the cold crystalloid into the renals. If the intercostals proximally are back bleeding a lot, we just oversew them, make a hole in the side of the graft. There's a lot of different ways to reattach intercostals, but these old leathery aortas, I think this does pretty well. So then we'll move the cross clamp down and restore flow to the intercostals. In this particular situation, we did a distal anastomosis at the bifurcation, which is actually a pretty nice bifurcation. And once that was done, we removed the clamp and restored flow distally. Although sometimes we'd like to move the clamp around the infrarenal abdominal aorta, sometimes just the anatomy is just not amenable to it. Then we go about reattaching the visceral vessels with the side branches. I worry about spasms sometimes in the cold, particularly the cold crystalloids, so we'll either put nipride or nitroglycerin into these branch arteries to the kidneys and help try to reduce the risk of that. And then this is taken out in AMDS. These are not fun to take out. We haven't taken out very many of them, but they can really make things challenging, and we have to be aware of that when we're putting them in. So this is a study we did of 3,470 thoracoabdominals, and we looked at primarily 1,119, or about a third of them, that had chronic aortic dissection. Mortality rate was 7.1%. At 10 years, about 10% of them had reoperation. You can see here that the ones with dissection are basically younger but have less comorbidities, such as coronary disease and cerebral vascular disease as well. And they also tend to be the longer aneurysms. Operative mortality is less, and permanent paraplegia is also less in these patients with chronic dissection. So we look at them over time here to 15 years. The patients with dissection actually do much better, but then once you adjust the analysis for age, sex, comorbidities, et cetera, there's really not a difference in survival. And the same thing goes for repair failure. So this is 3,829 thoracoabdominals looking at dissection in 1,400. Chronic dissection in 1,264. 521 were from DeBakey type 1s, and the rest were from DeBakey type 3s. Operative mortality in this particular situation wasn't much difference. There was a little bit less in the instance of particularly persistent paraplegia. So this is just a little bit more updated. So this is an example of a patient who had a previous Bentel, the kind of things we were talking about. Then he had a redo. Had a tissue Bentel, then a redo with a mechanical Bentel. This was done elsewhere. He was 49 years old when I saw him. He had Marfan patients, and this is what we did for him. This guy was 6'7". I operated on him this past Monday. He's very happy the next morning. And if you can see here on the picture on the right, Dr. David, he is actually raising his knees up. His legs fortunately work just fine. Now we've got Gustavo Oderich with us. He's a partner. He was at Mayo, then he was at Herman Hospital, and now he's with us. So this is the kind of things we're doing. I got this patient in 96, had a Bentel in 98, had a descending, and then ends up, Gustavo puts in this multi-branch graft to replace his thoracoabdominal aorta. You can see here, these are just the drawings of it, and you can the CT scan here, and he comes back after we did all of that. We did the proximal aorta and the transverse aortic arch. He's got a total replacement. So that's what we're doing. However, it doesn't always work. This is a patient with Marfan syndrome, extent 2 thoracobental and arch replacement. In 18, he was on ECMO, had a problem with that, had a VAD placed, and then he had a heart transplant, had a TVAR thrown in there for a while, and he had chronic kidney disease with creatinine of 2, and got an endovascular thoracoabdominal repair in 23. And I'm not going to go through all of his studies, but you can see here that thoracoabdominal multi-branch graft is really not doing him any good. And so in the lower half of this photograph, you can see that multi-branch graft coming out. You can see in the upper slide what it looked like before we actually opened the aneurysm. This is what our repair looked like, and he did extremely well. This is some comparisons between open and endovascular that Morale helped put together. helped. She did practically the whole thing. Anyway, the important thing here is my topic was chronic dissection, and she put in here that it favors open as opposed to endovascular where acute dissection might. So chronic dissection requires a multimodal tailored approach. We've got a lot of tools we're going to have to throw at these patients depending upon the pathology. High volume centers for these complex cases are probably managed best. We need to focus on reducing organ ischemia, which is particularly the spinal cord, and in all cases minimize intraoperative bleeding. So when I think of Dr. David, this quote came to mind: medicine is the most humane of sciences, the most empiric of arts, and the most scientific of humanities. And this is by Edmund Pellegrino. So thank you very much. It's truly an honor to have the opportunity to be here.